Look, thank you very much. Thank you for that welcome, Herbert, an introduction, and thank you to the panel for coming along. It's a great privilege to be here today, and we've got a number of people in the room, and as we go through the session, we'd like to make it interactive, so by all means, raise your hand. We do have some roving microphones that where you can ask a question later on over there to my right. Online, of course, please use the Slido. That'll come up in front of us, so we'll be able to take questions from you online. I'm the facilitator for the panel today, and I might just I'm going to ask each panel member before they answer their question just to talk a little bit about their digital journey. And I was looking at Danielle earlier, and I mentioned that I was ID number 59 for medical director in Australia. So I was the 59th practice that put the software in 1995. And according to Brendan Kieran, that would have made him 4 years old this morning, for those who did the maths. Perhaps he wasn't quite 4 years old at that stage. But we actually started writing digital prescriptions, not the ones we write today, but prescriptions digitally, and I can still look back and find them. If you look at medical records, and I'm a GP, if you look at medical records and look back, how far can you go back? Well, you simply can't dig out that information. But if a patient saw me in 1995, my current software at my practice, I can find out what I prescribed to them that many years ago. And if there was a reaction, I know that too. So that was just extraordinary. In fact, writing a digital prescription, I had not one, not two, but 3 phone calls from a pharmacist to thank me for buying the software because they could finally read my writing. And I think that's really important that, are we making things better? We need to ask ourselves the question. That's why we're here talking about clinical governance. I won't I guess my clinical journey, or my digital journey, went on. We computerised the practice. I was AMA president, you might remember, a few years ago, and the secretary at the time and the minister at the time asked us to do a review of the PCEHR. That was the Royal Review. So I was part of the Royal Review. And one of the things I remember from doing that review was when we went to the Northern Territory and we spoke to the people using digital health, they said to us, if you shut this down, we will pay for it ourselves. This is so useful that we just can't have it go away. So whatever you're doing in the review, please make it better, make it easier for us to use. And I think that's a message that we also need to think about in the future. If you've got something and when you turn it off, people can't live without it, how good is that? That means you got it right. Since then, of course, I was chairman of NETA, and that was an absolute privilege to start the journey. We started with standards, we started with agreeing on what we should be doing, and we handed over that to the agency. And I've been working with the agencies for a number of years, and also now the chief clinical advisor. So informally, if you like, for a few years, but now a full part of the senior executive team, and we'll talk about that this afternoon in another session. The question, what we're here for is to think about connecting care, and I thought I'd start with Professor Maghrabi. Let's think about the framework and the structures and the principles that underpin safe, connected healthcare. So I'd love you to answer that question, but love to hear about your digital journey a bit first, and then we'll move on from there.
Thanks, Steve, for that introduction, and thank you for the invitation to participate in this panel. So my journey has been kind of entirely digital health. I trained as an engineer and then went on to researching both the design and evaluation of systems. And I've probably focused a lot of my work on how not to do things or when things have gone wrong. And so, we heard this morning from consumers about exactly what they need. And so our job in terms of, the clinical governance is about sort of ensuring we do what consumers need at the end, but then also sort of trying to, implement some of the fundamentals that we have learned from implementing these systems pretty much over the last, 20 years. There is now good evidence in terms of how we need to go about implementing these systems. Neville did some fantastic work when he was with the Commission with these implementation guides. And for meds, management systems. And they kind of actually, they hold for a lot of other systems that we're implementing today. So some of those fundamentals, it's about kind of keeping those in mind as we start to, implement newer systems, telehealth, into the world of AI as well. And as I was kind of just saying to somebody this morning, when IT systems break down, yes, it does disrupt care delivery. But what is fundamental in terms of ensuring safety is the human sort of machine interface. So we know that when there are human factors issues, that's when we harm patients. And so the job of governance really then is to make sure that these interfaces work as we implement systems in different settings, because workflows vary. One system which works in one place is not going to work in the other. And so we have good evidence now. And so the job of governance is to kind of just make sure that we apply all of this into practice. And I'll stop there.
Thank you very much. Well, let's move on to Neville Board, who's the Chief Digital Health Officer of the Department of Health Victoria, but also a chair of our Jurisdictional Advisory Committee, and has to corral all of the other states. So I thought about your role, and I actually said to him yesterday, what were you thinking when you took this job? But it has to corral the whole of Victoria, and there are very, very many and varied systems in Victoria. And then someone gave him a bigger hat to say, well, look, you're doing pretty well in Victoria. How about you start helping us with the rest of the country? But it does make us remember that we're all in this together. We were reminded this morning there are 25 million people in this country, not 200 million people. So we've got to be able to get this right, and we've got to be able to make it work. But I'm sure that you've got some insights about both Victoria and your national work that you can help us with the connected care question.
Yeah, thanks for that, Steve, and thank you, everybody. Just will acknowledge I'm on the lands of the Gadigal people of the Eora Nation. Just in terms of digital, I've spent my whole career pretty much in health, and if you want things to get better, it's inevitable that you'll want things to be legible, you'll want things to be shared between teams, you'll want things to be accessible for things like virtual check-ins, and we want patients, citizens, it might be the offspring of older parents, in my case, or it might be people with kids, to be able to jump on, see their own stuff, book and get more engaged. There is good literature that when citizens can access their own test results, we actually kind of miss less important results, and similarly meds management will improve if the citizens are engaged. So that has been my journey of trying to improve the quality of healthcare, and you just come here, it's inevitable. I will reflect on chairing the Jurisdictional Advisory Committee and looking after digital in Victoria. So the first thing is everything's my fault. That's just a good default position. And I have to say at home it's the same, so I feel quite well prepared.
You should say everything good around here is my fault.
So on that, I think we are in a world now where you do not do a big single push-out build. So in Victoria, I'm very proud that health services, after a fairly detailed review of what works and what doesn't, that they choose, and we assure their big investments, whether it's a lab system or an EMR. We do as much work as possible to reduce that burden, and that I think that's useful as well. But you know that once you start getting that journey of legible things with decision support, how your hospital or community health service works really sets up how you configure it. So there's no right answer, because one hospital will call its neurology ward the Neurology Institute, and another one will go to a high dependency unit. So that's a natural world. And I think that's the world we're in. I'm very proud that in Victoria now, although we don't yet have connected care, and we're doing legislative work quite soon, I think, to take that further forward, we've now got in place in a very middle-out model, so going from Big Bang Health Smart, which, like a lot of states, didn't do so well the first time round, to Devolved, which worked really well, by the way, for the big health services like American Hospitals, works really well for Alfred Monash, done great things, Parkville. But I feel for rural, regional, small, we have to pedal harder, government, and that's the same in education and transport and everything. You have to pedal harder to support rural. So that's okay. But now, using that middle-out governance, we have got a nice, much better, safer, more redundant network. We've got unique patient identification in place. We've purchased a health information exchange to be a platform to lift mental health and pathology and eventually all information sharing. And been able to swap out a very unsexy project of putting new messaging engines across the state. So unsexy, but what a wonderful project. And each time you get those high achieving sites go first, they wear the pain with you, and then you cycle through, learning health system, everyone gets a little bit better. It's a really nice way to work. So I'm pretty excited that we're in a good space, Stephen. Thanks for the opportunity.
Look, thank you very much, and it's probably an introduction more than detail about what you're up to, but we might be able to explore that a bit more as we go. Danielle and Monica are both working in businesses that provide software to varying customers, and two major parts of the digital health system, frankly, two very, very major parts of the digital system. Danielle, you're supporting software to supply to general practice, specialists, and increasingly to allied health. So that's a big challenge, and I'd be very interested to your thoughts on connected care and about how the journey's gone, and I guess how you got to where you are.
Thanks, Steve. My journey's kind of interesting because it was an accident, to be honest.
So it was
All of us.
Neville's fault. Yeah.
Yeah, I was working as a locum in Queensland as a pharmacist when I graduated out of uni. And I guess, like, I actually didn't choose pharmacy. My parents did. They thought it'd be a great idea. I was one of those kids who had no idea. I thought I was going to go snowboard for my life. That was going to be my journey. But it was really interesting because I found it really frustrating how much paperwork and just unnecessary workflows there were for a clinician, and that was the bulk of my day. I didn't get to spend the time that I wanted or needed with my patients actually conversing face-to-face and making a meaningful impact. I could try, but there was still significant actual paper. So in a plan to move to Canada with my brother, I took an extra job to save some money. I actually am qualified in Canada to be a pharmacist. And I accidentally took this job. It happened to be with a prescription exchange software. I could read XML accidentally, and that's how I got a job. And from there, I just really, really got passionate about that user experience. How can we provide better workflows and better software for our clinicians? That is why I do what I do. Because every day we build software, it's not enough just to say we're done. You need to continue and to improve with the way that healthcare changes, our patients' needs are changing, the type of care they want is changing. And so the software has to change with it. I've been really fortunate to work on huge projects like e-prescribing for Fred, and also real-time prescription monitoring, and I was the lead designer for SafeScript. And that was probably where I saw, in coming back to the question, why it's really important to have clinical governance. The way that clinicians practice is all very different. Nobody has the same workflow, and you can't expect everyone to fit into a perfect sized, here is your user experience, here are the steps you must follow. Everyone's patients are different, the way they interact with them is different, and how they actually supply their business models is different. So you need to actually provide multiple ways of getting to the actual same outcome. Data is interpreted differently depending on the type of clinician, and the reason that we provide such detailed clinical governance and quality is to make sure that no matter what those outcomes are or how you use the software, you still get the right answer at the end for your patient. So the clinical governance has multiple layers, but it does come down to co-design, involving your clinicians early. We have an internal clinical governance group, which is multidisciplinary. We have a psychologist, physiotherapist, nurses, GP, pharmacist, and we also have an external advisory group where we actually get a range of not just our customers, but people who aren't our customers yet. How can they help us build better quality software as we provide the future software for them?
Thank you very much. And Monica, probably shouldn't tell us your whole CV, but...
How much time do you have, Steve?
But you've had vast experience both as a clinician at the front line of healthcare, in the public sector, in the private sector, in digitisation of that private sector, in organisations like the agency, and now you find yourself in Telstra Health. So we're really keen to have you to think about, to have your insights about connected care, about your reflections on that journey, and very interested in a little bit more about how you got to where you are.
Thanks. So first of all, I just reflect on, as I'm saying hello to everyone, I feel like we're amongst peeps and the church of the converted. And how cool is it that we have an event on clinical governance in digital health? When, going back to history and where we started, Steve, we were having events on why digital health is so important. And now to sit here and talk about clinical governance, it feels, every day you think, oh, have we advanced? But when we're talking about clinical governance in digital health, I do feel that we're moving forward. So shout out to the agency Turban and the amazing Liz Keane, who leads the clinical governance, for putting this together, because really, great job. Good job. Which goes back to, I think when looking at connected care and the journey, there's two main things, and one thing that we really need to tackle, and that is how burnt out our health workforce is. The burden on them and the noise around practice every single day is incredible, and that's something that we in digital health can really help. One, and Neville, you mentioned, by really looking at what we currently have and connecting what we have, instead of trying to bring new things in, that creates more noise. So connecting what we have, giving our clinicians a connectivity of something that they're familiar with, and working on foundations, really important, it's a connection. Second, make it something that is safe, and going back to the pillars of clinical governance, if you work on something that's gone through a clinical safety case, that has had an approach of clinical safety from the start, you know that the noise will be reduced. And again, I've got an amazing team here of people that work and breathe clinical safety, and that's everything that we do. We have clinical safety officers, we have to have clinical safety case, we have a clinical governance system. In Australia, we have one of the brightest and best minds. Some of them are in this room, some of them are to my right, on clinical safety. And really, we do have a wealth of resources to embed into the foundations of software the practices of what we do of inpatient care every day. And the third thing is we need to make systems smart. So we need to be able to look at the data, make them usable, make them modular, build on what we have, but also be able to run intelligence over that. And so it's really important that we have systems. And when you say all of those things, you say, oh, that is so ambitious, whatever you're saying, but look at what we have achieved. So if I say from my part of the universe, which is not the whole digital ecosystem, but if we go to connectivity and the work, for example, that the National Cancer Screening Register has done in connecting to all software systems, in connecting to all labs, we have the big labs connected into the NCSR now and into software, so that when a clinician has a patient in front of them, the noise and everything's reduced so that they can make a decision based on those on cancer screening as well. The same goes to aged care, and I saw George sitting around there as well. An area where we launched an app, and it was the uptake of an app where you can do all your workflow from the bedside. We have to give people tools that they use, right? And then smarts go back to connectivity. And I did get, I've got to put my fingerprint in this, some of the stats, because we've talked about e-prescription a lot. And when I looked at the stats, since ERX was launched in 2020, there have been 20 million. Out of those, 28,000 doctors prescribing 10 million, and 98% of pharmacies in repeats of 9.5 million. That was in 1 year. So, and that again, then you run intelligence over that, and now we've produced, we have an analytics and AI function that runs intelligence for pharmacists, going back to that can help them through AI give out the information for their dispensing as well. Quickly, done, easy. That's what we need to get right.
Yep. Look, thank you very much for those three comments, and I should ask Farah Maghrabi to put on her professor hat again and give you a mark out of 10 for application of the clinical governance principles. But you must be
She's got a conflict. She trained our CSOs. She's amazing.
She must be very happy to hear the detail that all of you have gone into about learning what people need and delivering what they need rather than imposing something that you think they need. But I'd love to hear your comments about what you've heard this morning, about what's being delivered by the states, if you like, by Telstra and by software for medical people, and we are running a
We
bit
do
short
have
of
a
time, but
question here.
there we go.
Look, I think from what we've heard, we've come a long way from where we were, even from back when we did the training at Telstra Health. But there is still a lot to do. The world of AI and ChatGPT and all of that is just coming our way rapidly, and it's changing so fast. So I think we have a way to go as well, but we're in a good position, and we have the right sort of skill set nationally as well to do it.
And it isn't static, it is about continuously improving. It's really something that we need to all embrace. Nev, the question is about health information exchanges. I wonder if you have a reflection on the value that you found in Victoria and the sort of things we should be thinking about nationally.
Well, he's investing in it.
Yeah, look, I think the reality is healthcare is complex. We had moments in the pandemic where our hospitals and the department engaged much more deeply with our registered community health organisations. So we've got about 26 registered community health organisations under the Health Services Act, and very clearly their bailiwick is marginalised populations, very much so. And so bringing them together with the hospitals in the model. So COVID was notifiable. This is in the pre-vaccination economy. But there's a whole lot of other non-public health stuff apart from, looking at people quarantining and things like that. Needs, unwellness, deterioration, people needing food and accommodation. So the reality is we're going to be pulling stuff together from different worlds, and health information exchanges, I think, are the way to go. I'm a great believer in my health record, and over the years I've spent a lot of time on it, but I think the next step is exchange rather than repository. So, and it's going to be complex, and it's not going to be buy one and turn it on. It's, can you have a conversation with haematologists, and can you have a conversation with radiation oncology and work out what a good précis looks like? There's a lot of work ahead of us, but I think that's where we want to go. I think we're all pretty good at security, but we need a good public discourse on security. I think they're all now very configurable for privacy. And healthcare is complex, so we just keep churning forward. But I think being able to look up something from another hospital helps me manage the patient in front of me, and that's a good thing.
Yeah, thanks, Monica. Yep.
Can I make a comment? Because what we're seeing about HIEs globally and internationally is that is what's bringing the different systems together. So if you look at the One London experience, where they got all the different boroughs and they got all the exchange to create one London record, that is the potential of what we have to make the most of something that works for the individual systems and bringing that together. So whether you call it an HIE, whether you call it the longitudinal record, whether you call it one, you just need to have a platform and ecosystem approach that can talk to each other and connects it all to create one record for the consumer, but also creates the vision from along the journey in their life, whether they're in a maternity area, whether they are looking after their elderly parents, but also for clinicians at different point of care and anyone providing care. So whether you call it HIE, it's an interop platform, really, that needs to connect.
And we probably should move on from the individual record thought to getting access to the information about me whenever I need it, wherever it is.
Yeah.
And Danielle, yes, I'd love to hear what...
Yeah, I just wanted to lead on from that. I guess the reality is it's not only putting the patient at the centre, and it is about building a longitudinal, it doesn't really matter what you call it, it's a record, but it's really about bringing clinicians on that journey as well, and making sure that there's trust in the data. Because the biggest problem when trying to implement new systems of bringing people along and actually getting them to invest in a journey is providing them quality, safety, and accuracy. So as we start exchanging data, it's not about technology and standards. We can agree to that. That's actually already there. Technology is not our complex problem. The complex problem is ensuring how I exchange the data makes sense when I send data into a hospital, and how the GP data coming back in makes sense, how I can actually utilize that data within my software, how I can interpret it across different disciplines. So it's more about how you display it together, how you display it, how you actually govern those frameworks, improve the security and the data around it, rather than the underlying, you must do a standard.
Mm. And how actually at the end of the day clinical decision support can lift that data and move it around, make something sense and provide some sensible advice for that patient at the time.
Well, it's a really interesting one, the CDS, because just quickly, I guess the point to that is there's more and more third-party apps that our clinicians are actually relying on, and it's really important that we actually provide safety and quality around those apps as they integrate as well, because the CDS, they want to be able to rely on that data and make sure it's accurate. So it's ensuring we have partner programs in place that are assuring those programs back to our actual users.
I think we're getting the wind up, so I think we stole an extra 6 minutes. But look, I would really like to thank the panel members, the audience, the people online for the questions. This is the sort of level of the conversation we're going to have today. So there's lots more presentations this afternoon that we'd like to welcome you to. The panellists and I will be floating around for a little while, so you can certainly ask any questions directly. If there are any other questions, we'll answer them and come back to you. Now, I think I'm not inviting Dr. Rochford back on. I'm inviting Dr. Herbert back on.
Yeah, I'm the substitute Dr. Rochford. You can tell, right? If I stand sideways. Thank you to our panellists. The wealth of knowledge and the generosity of each of these individuals coming here today and sharing their expertise is really terrific. Thank you to Dr. Steve for chairing. If you'd like to take a minute or two to stretch your legs, please feel free to swap to the other room if you'd like to join the other panel. Other than that, we will get started on our next panel in just a couple of minutes.
Sorry, Herbert, the other panel's not as good, though.
Definitely.
I have no opinion to offer on that, Mr. Board.